So thank you, Sham. You made my talk much easier to do with that exhaustive uh, talk on classifications, and thank you for inviting me here. What I will be talking about is raised intraocular pressure and ocular trauma. So let's see with this patient who all of us generally get in our OPD. This was a 48-year-old gentleman. He came with a history of a blunt injury with a ball. He had also nasal bleeding and vomiting. He didn't have any systemic illnesses, and his unaided visual acuity was 618 N36 in the right eye and 66 N10 in the left eye. So this was his, he had a lower orbital margin which was not felt. There was crepitus, there was tenderness, there was a restriction in extraocular movements looking upwards. Slit lamp examination showed microcystic edema. There was a hyphema. The pupil was dilated in the right eye. Left eye was normal. Fundus examination you could see hazily, but yes, the disc appeared just okay. The rest of the retinal details were not very clear, and in the left eye it was normal. So an ultrasound was done, which was normal, and since he also had that crepitus of CT orbit was done, which showed emphysema, blowout fracture of the floor and medial wall, but no muscle entrapment. So the provisional diagnosis was a secondary glaucoma following a blunt trauma with a traumatic hyphema. We leave the second 4, 5 and 6 because that's not what I am talking about. But what I am talking about is traumatic glaucoma. So this could develop either like Sham said, following a blunt or penetrating trauma, and yes, it occurs more commonly in the elderly where they fall, or in young people who play sports or have assaults. Based on the etiology is how I am going to describe them. I'll describe a few of them for paucity of time. So why does hyphema occur? Hyphema occurs because of the anterior-posterior compression of the globe and an equatorial expansion. This leads to tearing of the blood vessels of the ciliary body and stromal iris. Another etiology is that because of a sudden rise in intraocular pressure because of the trauma, the fragile vessels of the iris or ciliary body can tear, and these cause the presence of hyphema is because of a blockage of the trabecular meshwork. It's more in patients with the sickle cell trait, so you need to just confirm with them, though not very common in India. So when you look at the patient, you need to measure and see how big the hyphema is. You need to measure it from the inferior corneal limbus. You need to look at the color, whether it's red or black. Red is fresh. If it is black, it is generally called the black ball or 8-ball hyphema. It means the aqueous circulation is impaired and there is decreased oxygen concentration. So what complications can occur with hyphema? You can get a corneal blood stain, and this is more when the hyphema is of a longer duration and of an increased height. It's more commonly seen in patients who have a corneal endothelial dysfunction or an increased intraocular pressure which was more than 25 millimeters of mercury for 16 days, 6 days. There is an injury of Descemet's membrane can also cause corneal blood staining, and rebleeding is a risk factor. What is rebleeding? Rebleeding is when the initial clot closing the torn blood vessel retracts and undergoes lysis, the bleeding occurs. It generally is more severe than the initial bleed and can lead to complications like corneal staining. It occurs within the first 5 days of surgery, and that's the reason why you need to avoid gonio and hyphema patients in the first week. The risk factor for this is an hypotonia or elevated intraocular pressure, systemic hypertension, and anticoagulant use. So, well, how do you manage a hyphema? You need to tell the patient to raise the head end of the bed, keep the head end elevated, so when they are sleeping, give steroids. This is to reduce the inflammation. You could start with topical and then move on to systemic. Relieve the ciliary spasm by giving cycloplegics. Reduce intraocular pressure with aqueous suppressants. Start off with aqueous suppressants. If the pressures are not low enough, you need to give systemic carbonic anhydrase inhibitors, because again, in patients with the sickle cell trait, it can increase the sickling tendency. So surgical management is when your intraocular pressure is uncontrolled, more than 50 for 5 days, 35 for 7 days. You're getting any corneal blood staining, 8-ball total hyphema, then you need to go inside, wash the blood off. You can use a vitrectomy instrument, then it's a smaller opening. And if the pressures are very high, to tide over the acute phase, you can think of a trabeculectomy. Well, what are the other causes of an early onset glaucoma? They could be because of a trabecular meshwork disruption. This can be seen on gonio. When this heals, it causes a scarring and damage of the outflow apparatus. The next is traumatic iritis, which can cause. How does this occur? When you have a blunt injury, there is death and necrosis of the cells. This triggers an inflammatory reaction, causing a breakdown of the blood aqueous barrier, causes the influx of the WBCs and inflammatory mediators, which causes an increase in intraocular pressure. In very severe traumas, you can end up with choroidal hemorrhage, and choroidal hemorrhage can cause a forward displacement of the lens iris diaphragm, leading to angle closure. Well, what about the late onset glaucoma pathophysiology? The most common is angle recession, but this is generally in patients who are genetically predisposed. How does this occur? When you have a blunt trauma, the aqueous pushes laterally and posteriorly. The lateral push causes a traction on the iris root and causes a tear between the longitudinal and ciliary body muscle. This also causes a collapse of the Schlemm's canal and fibrosis of the trabecular meshwork, causing increased intraocular pressure. The other theory is that there is a growth of hyaline membrane over the trabecular meshwork. Management is like any primary open angle glaucoma, but these are more resilient to treatment. So you start with aqueous suppressants. You can give prostaglandins. These would help because there is an increased outflow through the uveoscleral pathway. But you would reduce the, you would not want to use pilocarpine because trabecular meshwork outflow is as such not working, and pilocarpine also reduces uveoscleral flow. In some people have advocated that in patients who are resilient to treatment, you can try atropine, cycloplegics, that can help reduce the intraocular pressure. There is no role of laser, and one can use the other option once pressures are uncontrolled is to do a trabeculectomy or a tube. The next is a ghost cell glaucoma. This occurs when there is vitreous hemorrhage. The RBCs denature, they form ghost cells, and when the anterior hyaloid ruptures, they accumulate in the anterior chamber. They obstruct the aqueous outflow and increase the intraocular pressure. So this is what they look like. If you have a rebleed, you can get a candy stripe appearance, and the management of this is to clear the vitreous hemorrhage off. That is the definitive treatment. Medical has less role, but you may need to give oral carbonic anhydrase inhibitors. But if the pressures don't come under control, one would need to do a trabeculectomy or a tube glaucoma drainage device. The lens induced, this can occur because of dislocation, which can cause the vitreous to prolapse in front, cause a sort of a pupillary block, or if it is subluxated and just vitreous coming in front, it can block the trabecular meshwork and cause glaucomas. If the anterior capsule is punctured, it can lead to a phacolytic type of glaucoma where you need to do a cataract extraction and put in an intraocular lens. The secondary to penetrating injury, the more you can get synechial, but I'll deal with just the epithelial downgrowth. Over here, the stratified epithelium from the cornea or conjunctiva, they start migrating through the wound. They form a sheet over the trabecular meshwork. They can occur any time from 3 months to 10 years, and the glaucoma is because of blockage of the trabecular meshwork. Over here, glaucoma drainage devices are the mainstay, and you would need to devitalize the epithelium using cryotherapy. Medical therapy, TRAB, and generally don't work. The last is a cycloablative procedure. Well, we had this young girl who was playing outside her house, and there was a stone which was there on the road. A car went past, that stone came and hit her, And this is the sort of injury she had. We took her up in the night, it took us 2 hours, and all her ocular contents were nearly out. The initial call which I got was that it's just soft, we are doing FT, we can't see, there is a total hyphema. A detailed history is important. You need to do a visual acuity assessment, inspect the eye, see for RAPD, very, very important. Try to do a torchlight, if not a slit lamp examination. In an open globe, no gonioscopy, do a fundus evaluation. But most important, protect the eye and educate on eye safety. Thank you.
Thank you, Dr. Vineet. A very exhaustive presentation and a very informative one. Just wanted to know, when do you advise a trap in acute setting?
Acute settings is when your intraocular pressures do not come under control based on your, even after giving maximum medical therapy, and you start seeing disc changes. So once you start seeing disc changes, you would need to think of a trabeculectomy. In the earliest, if you do it in the earlier stage, because of the inflammation, the traps would tend to fail. So you have to find that golden period when you would, the inflammation is reduced, but pressure is still high, and then go in.
And antibiotics you prefer to use?
Yes, mitomycin, and over here you would want to use 0.4 rather than 0.2.
Thank you, Dr.